Good evening, dear students. Welcome to you from Sri Rama Hospital, Jagapet. In the previous class, we were studying about the tumors of the pancreas. We studied about the pathology, clinical features, and investigations of a neoplasm of the pancreas. The most common neoplasms of the pancreas being carcinoma of the pancreas. In the carcinoma of the pancreas, carcinoma of the head of the pancreas is more common. Hello, see whether am I audible? Can't hear? Hello, hello. Are you able to hear me? Hello, dear students. Can you hear me? Hello? Acha. Okay, that's fine. Because someone has given me the message that they are not able to hear me. Oh, that's fine. Okay. In the previous class, we learnt about the investigations of the carcinoma of the pancreas. So the patient will usually come to you with obstructive jaundice features. So we do a clinical examination and evaluate whether the patient is having obstructive jaundice or not. Then we will do biochemical investigations to confirm that he is having cholestatic jaundice. If he is having cholestatic jaundice, then what we do is we go for ultrasound scan that will demonstrate the dilated bile ducts, both intrahepatic and extrahepatic. Then we'll go for ERCP, and if any obstruction is there, we'll do stenting. Breast cytology can be taken if a mass is there, or FNAC can be taken, or biopsy can be taken from periampullary tumors. CT scan is done to know about the T stage and N stage as well as secondaries in the abdominal cavity. Endoscopic ultrasonography is done and FNAC of the pancreatic masses is done. So these are the investigations. Then the management. Management depends upon the site of the tumor, whether it is there in the head of the pancreas, body or tail of the pancreas. Operability of the tumor. Already explained to you, a tumor is operable if there is no infiltration to the surrounding tissues and if there are no metastases. And fitness of the patient. This is a very formidable and major operation. So you will evaluate whether the patient's general condition and vital organs and systems are able to bear this insult of surgery. So what are the signs of operability? Absence of local invasion into portal vein or its tributaries, local invasion into stomach, transverse colon and retroperitoneum, Most of the cystic tumors and neuroendocrine tumors are operable. Tumors less than 4 centimeters in diameter. Absence of loco-regional lymph nodes. So if these criteria are present, then we will consider this case as operable case and we'll go ahead and do the surgery. Then of course, absence of secondaries in the liver and peritoneal implantation. Cystic neoplasms have to be resected, though they are large in size. Periampullary carcinoma is usually operable because of its early presentation. So signs of operability means you have to evaluate on CT scan and endoscopic ultrasonography itself whether there is any local infiltration into the neighboring organs, whether there is any infiltration into the portal vein or superior mesenteric vein. Then check for the lymph nodes draining the pancreas. Then check for secondaries in the liver and peritoneal over the peritoneum and in the Douglas pouch. Tumors of the body are usually inoperable because by the time they come to the surgeon, the tumors will be in a very advanced stage because in the early stage they are asymptomatic. So patient cannot identify that he has a mass in the pancreas. The management: head tumors, operable tumors, and fit patient. So I told you, operable tumors, the treatment is curative resection. What is meant by curative resection? The mass along with the organ, its lymphatics, and the lymph nodes, the nearby lymph nodes. All has to be removed as one piece, that means one block. So this is also called block dissection or curative resection. Only 5 to 10% of the patients belong to this category. The surgery is pylorus preserving pancreatoduodenectomy. So this is the operation that is being done. In this, the duodenal sea lobe, pancreatic head and neck, terminal bile duct are removed, followed by reconstruction. This is the operation of choice. So what is this procedure? Just I will explain you in the next 2 or 3 slides. Classical Whipple's pancreaticoduodenectomy. This is pylorus also is removed. Is done in case of duodenal infiltration. So why pylorus is removed and all that, I will explain after I show you the slides about the pancreaticoduodenectomy. The structures removed: duodenum and head of the pancreas, common bile duct along with gallbladder, related lymph nodes and superior mesenteric lymph nodes. Some surgeons remove pylorus of the stomach also. Reconstruction: proximal jejunal loop is anastomosed to the common hepatoduct, pancreas, and pylorus. Just I will explain you in these slides the procedure. This is the pancreas with its lymphatic drainage and lymph nodes. Any curative resection means, for example, a mass is here. This mass is very small in size, only about 3 centimeters by 2 centimeters, suppose. Now, what do you want to remove? You want to remove not only this mass, because it is malignant. A malignant tumor, macroscopically, these are the margins. But microscopically, the tumor cells must have gone into surrounding areas also. How much surrounding areas it can pass? It can pass to about 2 to 2.5 centimeters. And the tumor cells, microscopically, they must have passed into the lymphatics also. That is why the plan of management for an early tumor for early cancer is removal of the mass along with the surrounding 2.5 centimeter margin. If possible, remove the organ from which the swelling is arising or the mass is arising, and remove all the lymphatics draining from this mass and the nearby lymph nodes. So, can you see the lymphatics? You can't see the lymphatics. The lymphatics are mostly passing along the blood vessels. So, the lymphatics will be there throughout the tissue, and ultimately they go along the blood vessels and they end up in the local or regional lymph nodes. So, our plan is to remove the mass along with the organ, and also we want to remove the blood supply supplying that particular organ. That means, if you, for example, this is the pancreatic head tumor. What are the blood vessels supplying to this one? You can see here, this is the hepatic artery. The hepatic artery is giving this gastroduodenal artery. The gastroduodenal artery divides into two branches. What are they? What are the divisions of gastroduodenal artery? What are the divisions of gastroduodenal artery? Yes, superior pancreatoduodenal, excellent. There is one more. There are two branches. One is superior pancreaticoduodenal, another is right gastroepiploic. Another is the right gastroepiploic. So these are the two vessels of the gastroduodenal artery. So you can see here, the gastroduodenal artery supplies through superior pancreatoduodenal. Then here is the superior mesenteric artery. It gives off inferior pancreaticoduodenal. And you can see lymph nodes are there by the side of superior pancreatoduodenal as well as to the side of inferior pancreaticoduodenal. So you can presume that there will be lymphatics passing along these blood vessels to these lymph nodes. So these are all the lymph nodes which can be involved in pancreatic cancer. Though they are not involved, before their involvement, we will remove the lymph node, because lymph nodes acts as a basin where the tumor cells are collected before being disseminated far and wide. So if you can remove these lymph nodes also, regional lymph nodes also, along with the tumor, then you are going to get a good survival rate. So for this, what we should do? We must ligate the gastroduodenal artery, and we must ligate the inferior pancreatoduodenal artery where it arises from the superior mesenteric artery. That means here. Now if you ligate this and ligate this, pancreaticoduodenal supplies not only the head of the pancreas but also the duodenum. So you want to ligate here and you want to remove this part of the distal part of the blood vessels along with the tumor and the pancreas. So this pancreas head and neck you want to remove. Along with that, you want to remove the lymphatics and tissues all around these blood vessels, so that the lymphatics also will come away with that. So when you ligate the superior pancreatoduodenal and inferior pancreatoduodenal, then the duodenum also is going to become avascular. So you remove the pancreas as well as the duodenum also in the surgery. So this is the thing you remove. And the lymphatics go along the bile duct. So you remove the terminal bile duct along with the gallbladder and lymph nodes in the porta hepatis. So the structures that are removed are head of the pancreas, the neck of the pancreas, the C loop of the duodenum, lower end of the common bile duct, along with cystic duct and gallbladder. And this should include the lymph nodes in the porta hepatis, the lymph nodes around the gastroduodenal artery, the lymph nodes around the origin of inferior pancreaticoduodenal artery. So all these tissues are removed as one piece or one block. So this is the radical resection for carcinoma of the pancreas. Pylorus. Pylorus has to be removed or not. In the original Whipple's operation, the pylorus of the stomach is also removed. Why was it removed? It was removed because of the reason that the gastroduodenal artery has two branches. One is right gastroepiploic artery, another is the superior pancreaticoduodenal. So the lymphatics may pass along the right gastroepiploic artery also. So if you have a wider lymphatic field clearance, then the survival will be better. That is what Whipples has thought, and he has removed the pylorus. That is number one reason. The second reason is if you preserve the pylorus and do the anastomosis to the bowel, there will be delayed emptying of the stomach. The pylorus contracts and then there will be delayed emptying of the stomach. That is why people started removing the pylorus also. The third reason is pylorus has the antral G cells. They are responsible for secretion of gastric hydrochloric acid, apart from the other factors. Because G cells, they secrete gastrin. When you are doing resection of the stomach and anastomosing it to the jejunum, if antrum is present, the stomach will be secreting more acid. More acid, when it flows directly into the jejunum, it can lead to stomal ulcers. To prevent that one, if you remove the antrum, so the incidence of ulceration in the jejunum will be very, very less. So with these three aims, the pylorus was removed. But after few years, it was found that these three reasons were not scientifically founded. That is why people started doing pylorus preserving Whipple's operation. That means they preserve the pylorus and remove the duodenum only. I hope you got the point and you understood this technique of Whipple's resection. So these are the organs that are removed. Then how to anastomose? So in the classical Whipples, the pylorus is cut. In the modified Whipples, pylorus is preserved. So you cut the pylorus, you cut the common hepatic duct, and you cut below the duodenojejunal junction. Then you remove all this as one piece. So this includes the lymphatics, lymph nodes, everything. The tumor also is here. So in this process, you must be careful enough to preserve superior mesenteric artery and superior mesenteric vein, as well as the portal vein behind the neck of the pancreas. You must be because pancreas neck is very, very closely adherent to the inferior vena cava, and there are minute tributaries going from the portal vein. There are minute tributaries going from the neck of the pancreas into the portal vein. So they are very slender. So you must always ligate all those small branches and remove the neck of the pancreas along with the head. So after resection, you will see this is the stomach, this is the body of the stomach, here it is the body of the pancreas, common hepatic duct, this is the jejunum, upper end of the jejunum, this is below duodenojejunal junction. Now what you do is, you bring this jejunum upwards, and anastomose to the body of the pancreas. You have cut the pancreatic body. So you isolate the ducts and then put a stent in the duct, and then you anastomose the pancreatic surface, cut surface to the jejunum. Then anastomose the common hepatic duct to the jejunum as end to side. Then here, after these two anastomoses are being done, then anastomose the stomach to the jejunum. So there are these three are being anastomosed to the jejunal loop. So their secretions now will flow into the jejunum. So this is how the people's pancreaticoduodenectomy operation is being performed. Sometimes you have to go for total pancreatectomy. This is done in case of carcinoma head of the pancreas with associated multifocal tumors or friable pancreas due to chronic inflammation. Sometimes there may be associated chronic inflammation. So the pancreas is friable. Then in such a case, if you do the anastomosis of the body of the pancreas to the jejunal loop, there is chance of pancreatic leakage. Pancreatic leakage causes a lot of morbidity. That is why what you do is you remove the whole of the pancreas. When you remove the whole of the pancreas, the exocrine secretions and endocrine secretions will be totally abolished. So you have to give supplementation with oral pancreatic enzymes with every meal, and you have to supplement insulin to the patient after doing total pancreatectomy. For inoperable tumors, or if the patient is unfit for such a major operation, then you have to go for. So what is the trouble in this patient? What is the main symptom with which the patient of head of the pancreas tumors suffer? What is the most distressing symptom for the patient? Yes, gastric outlet obstruction occurs only in few, but all the patients who come to you with carcinoma of the pancreas, the symptom means they come to you with obstructive jaundice. And what is the main problem with obstructive jaundice? With which they suffer from? What is the most distressing symptom in the symptomatology of obstructive jaundice? Which symptom will make them suffer most? They will beg you. Yes, that is the pruritus. 24 hours the patient will be having pruritus. Morning, day, night, they can't have the sleep. They're going on scratching, but they don't get any relief. So that is the most distressing symptom of obstructive jaundice. So the patient with carcinoma head of the pancreas, their main suffering will be due to pruritus. You want to remove the tumor, but the tumor is inoperable because it has infiltrated to various surrounding organs, or it has infiltrated the portal vein, or the patient is very feeble, his cardiac condition or pulmonary condition is not suitable to undergo such a major operation. Then what you do? As you cannot do the surgery, that means because it is inoperable, or patient is not fit, so you have to relieve the symptom of the patient. The main distressing symptom is pruritus, which is due to obstruction to the bile duct. So you find some bypass for the biliary ducts. So what you do is biliary enteric anastomosis as a palliative procedure to relieve obstructive jaundice. So you can do choledochojejunostomy or cholecystojejunostomy. Choledochojejunostomy means you anastomose this loop of jejunum to the common bile duct. You take it here and anastomose to the common bile duct because it's already dilated, so it is easy to perform the surgery. Or you can anastomose to the gallbladder directly. Sometimes cholecystojejunostomy will not function very nicely because the walls of Hester will prevent complete emptying of bile from the bile ducts. So that is why the patient may not find complete relief from jaundice. But if you anastomosis with the choledochojejunostomy, then the relief of symptoms will be very good. So this is the preferred one. Choledochojejunostomy is preferred. If it cannot be done because of the nearby tumor, then it is better to do cholecystojejunostomy. If possible, you can go for stenting of the common bile duct by ERCP. If ERCP is not possible because the tumor has completely infiltrated the common bile duct, you can't pass the stent or even guide wire, then what you do is you do PTBD. I hope you know about PTBD. What is PTBD? If you don't know, you tell me, I will explain. What is PTBD? Yes, very good. It is percutaneous transhepatic biliary drainage. I told you already PTC, percutaneous transhepatic cholangiography. So when you do cholangiography, then what you do is you pass a guide wire, and over the guide wire you pass a tube and leave the tube outside to drain the bile ducts. This is called the PTBD. If there is duodenal obstruction, then you can do either gastrojejunostomy or duodenal stent. Self-expanding metallic stent will be there. The stent can be passed into the duodenum and you can place this in this duodenum. So this is the palliative management for carcinoma head of the pancreas tumor patients. So majority of the patients, they belong to this category. They need this palliative surgery. The curative surgery is feasible only in 5 to 10% of the people. About 90% of the people, they need to have any of these procedures. T-tube is not called as PTBD. T-tube drainage is called T-tube drainage only. And T-tube is placed in the common bile duct. PTBD means it is percutaneous transhepatic biliary drainage. That means you pass the tube directly into the liver. And in the liver, the dilated bile ducts will be there. So into those bile ducts, you pass the tube. That is called PTBD. For body and tail tumors, operable tumors go for distal pancreatectomy. Inoperable tumors go for palliative measures for relief of pain. The main symptom in these patients with body tumors and tail tumors is severe backache. So the backache can be relieved only by doing transthoracic splanchnicectomy or CT-guided splanchnicectomy. You can use splanchnic block by injecting absolute alcohol into the splanchnic ganglia. So of course, for the pain relief, in palliative treatment, you can use stepwise escalation of analgesia. Already I described about the stepwise therapy of the pain, of chronic pain, celiac plexus block. If it is not successful, then go for transthoracic splanchnicectomy. The patient is having steatorrhea, give him enzyme replacement. Treat diabetes. If he is having diabetes, you have to treat him with insulin. Consider chemotherapy. Indications of chemotherapy, inoperable tumors, and as well as adjuvant therapy following surgery. What's meant by adjuvant therapy? Adjuvant therapy means whenever you do a curative resection, there may be some amount of cells floating in the blood circulation. Though there are no metastases, but still microscopic presence of cells may be there in the bloodstream. So that's why what many surgeons do is, after doing surgery, they will give chemotherapy for a few weeks or few days. The aim of giving chemotherapy is those cells which are circulating in the bloodstream can be taken care of. That is called adjuvant therapy. So any chemotherapy or radiotherapy given after surgery is called adjuvant therapy. There is one more word called neoadjuvant therapy. What is neoadjuvant therapy? So the post-surgical treatment with chemotherapy and radiotherapy is called the adjuvant chemotherapy, adjuvant radiotherapy. What is neoadjuvant therapy? Yes, that's good. Given before surgery. Why do you want to give before surgery chemotherapy? Why do you want to give chemotherapy before surgery? To reduce the staging. Very good. And to reduce the grade. If the grade of the tumor is ill differentiated, if you give radiation or chemotherapy, then it becomes moderate differentiated or well differentiated tumor. So that is called the downgrading the tumor. Similarly, if a tumor is in stage 3, if you give chemotherapy for a few days before surgery, the stage 3 tumor will become stage 2. So again, you are doing downstaging. So neoadjuvant therapy means chemotherapy or radiotherapy given before surgery with the aim to downstage and downgrade the tumor. So if downstaging tumor means what happens? An inoperable tumor, that means a tumor which is of T5, 5 centimeters or 6 centimeters in diameter, you consider it as inoperable. You give chemotherapy for 4 weeks. Again, do CT scan. The tumor has shrunk in size, it is in 3 centimeter size. That means now it has become operable. So an inoperable tumor can be converted to operability. So that is the advantage of giving the neoadjuvant chemotherapy and radiotherapy. So this is to downstage the tumor and downgrade the tumor. So indications for chemotherapy here are inoperable tumors and as well as adjuvant therapy for following surgery. The drugs used are the 5-fluorouracil gemcitabine. Prognosis: mortality following Whipple's operation is about 3 to 5%. Morbidity, post-operative complications will be very many. They are about 40%. Many of the complications are due to pancreatic leak and complications due to infections. After successful Whipple's operation, the patient can survive for about mean survival is average 20 weeks. So the surgery is done for about 4 or 5 hours. The patient spends around 2 to 3 lakhs, and there is a chance of getting 40% of complications and 5% of death rate. And if he succeeds all these things, he survives for about 20 weeks. So that means this tumor is not at all a good tumor. There are some good tumors. For example, thyroid carcinoma, papillary carcinoma, thyroid, follicular carcinoma, thyroid. In early stage, if you do, you can give guarantee to the patient that he will survive for more than 20 years in about 95 to 98% of the cases. Similar colon cancer, well differentiated, stage 1. If you do surgery, then you can give assurance to the patient that they can survive for more than 20 or 25 years. But here, after doing such a big operation, the patient's survival rate is only just 20 weeks, 6 months or 5 months. 5-year survival is less than 3%. Ampullary carcinoma, they will have good survival rate of more than 40% because though the tumors are very small in size, the patient manifests with the symptoms. So that's why they will present to you early and you can do early resection. So earlier, the better always. Similar duct cell carcinoma, they carry prognosis survival of 20%. Then endocrine tumors of the pancreas. The endocrine glands of the pancreas are constituted by islets of Langerhans. The islets contain these cells. The beta cells, which produce insulin, they constitute about 75%. The alpha cells, they produce glucagon, and they are about 15%. The D cells, they produce somatostatin. They constitute about 8%. There are other polypeptide secreting cells which constitute about 2%. They are the VIP cells and G cells. So out of these various cells, these can produce tumors. So when they produce tumors, they produce the functional disturbances by secreting more of their hormones. So due to the excess hormones, the patient comes to you with certain clinical manifestations and problems. These constitute 1% of all pancreatic tumors. The tumor of islet cells may be in the form of diffuse hyperplasia, localized adenoma, multiple adenomatosis, and carcinoma. So carcinoma is only in 30% of the cases, 70% of the cases they are benign tumors. So benign tumors can be in the form of diffuse hyperplasia of the whole pancreas, or single adenoma, or multiple adenomas, or a carcinoma. %60 of the tumors occur in the body and tail. The tumors may be part of MEN syndrome. What is MEN syndrome? Is multiple endocrine neoplasia. So there is one doubt from one of our colleagues. Even in distal pancreatectomy, we remove blood supply. Then do we have to remove the duodenum even in this? No. This I will show you the blood supply, then you will understand. This is the pancreas. So this is the head and neck tumors. These are the body and tail tumors. The head and neck is supplied by gastroduodenal artery, and from superior mesenteric artery, inferior pancreatic duodenal. The body and tail are supplied not by these vessels. They are supplied by splenic artery. It goes like tortuous vessel and supplies to the spleen. So before going to the spleen, it gives off branches to the pancreas, body and tail. So when you want to remove body and tail, you have to ligate the splenic artery here. Because you are ligating splenic artery, you must remove body and tail of the pancreas along with spleen also. Spleen has to be removed then, not the duodenum. I hope you understood this point. So there is no need to remove duodenum in case of body and tail pancreatic tumors. There you have to remove the spleen. Okay. Let's come back to endocrine tumors of the pancreas. The tumors may be part of multiple endocrine neoplasia syndrome. The tumors arise from specialized cells called Eput cells. Eput cell means amine precursor uptake decarboxylase cells. They're special cells. Those cells, they produce various hormones. And hence these are also called as epidomas. B cells, they produce insulinomas. A cells produce glucogaminoma, D cells they produce somatostatinoma, and VAP cells they produce VAPoma or WDHA. WDHA means watery diarrhea, hypokalemia, and echlorhydria syndrome. G cells they produce gastrinoma, and gastrinomas cause Zollinger-Ellison syndrome. So these are the various endocrine tumors caused by the islets of Langerhans cells of the pancreas. So out of these, the insulinoma and gastrinoma are common, and we have to know about these things. Insulinoma, also called the beta cell tumor, also called the hyperinsulinism. It is insulin-producing tumor of the pancreas causing Whipple's triad. Incidence 2 to 4 cases per million of population. Age 30 to 50 years. Sex females predominate. Etiology not known. 90% are solitary and 10% are multiple. They are associated with MEN1 type syndrome. 10% of them are malignant. Malignant lesions are more than 2 centimeters in diameter and with metastasis. They will be having metastasis in other organs also. Clinical manifestations, they secrete more of insulin. So because insulin is secreted more, the patients will have these problems. They are hypoglycemic symptoms and neuroglycopenic symptoms. That means there will be hypoglycemia. This hypoglycemia will cause certain neurological symptoms because of glycopenia. So what are they? Blurred vision, diplopia, confusion, abnormal behavior, amnesia, and sometimes with coma. There may be reflex secretion of catecholamines to counter this hypoglycemia, because the anti-hypoglycemic hormones in the body, the first and foremost one is the adrenergic hormones, then adrenocortical hormones, then glucagon. So the adrenergic hormones, they immediately respond to this hypoglycemia because they can produce glucose in the body by neoglycogenesis. They break down glycogen, they break down fat, they break down proteins to liberate the glucose. So that's why catecholamines are produced as a reflex action. So because of the excess amount of catecholamines, the patients will exhibit sweatings, tremors, palpitation, anxiety, weakness, and hunger. So there is a combination of symptoms. Some symptoms are because of neuroglycopenia, and some symptoms are because of hyperreflex secretion of catecholamines. And these symptoms can be episodic. That means they may be there recurrently now and then. So they may not be there constantly. For 2 weeks or 3 weeks, the patient will have these symptoms, then they subside. Then they reappear after a month or two. So like that, they will be having repeated attacks. So there are 3 stages in the disease. First stage, pain or discomfort in the upper abdomen relieved by food. That is the first stage. Second stage, trembling, sweating, blurring of vision, and hunger. These symptoms will develop. Third stage, the patients will go into convulsions leading to coma, especially even after a slight hypoglycemia. That means if they fast for even for more than 1 or 2 hours, then they routinely do the fasting. Normal fasting is they take the dinner at about 8 to 10 p.m. in the night, and in the morning from 8 to 10 p.m., 10 a.m., the persons will have breakfast. So normally there will be about 10 to 12 hours of fasting. So if this fasting period is prolonged, then they can develop these things. In the first stage, they will have these problems, then second, then third stage. What is Whipple's triad? An attack comprising 3 stages described above after exercise or during fasting. During the attack, the blood glucose is below 45 milligrams per 100 ml. The symptoms are relieved by glucose. Investigation. Biochemical investigations. Blood glucose, C-peptide levels, and insulin estimation should be done during fasting. In insulinoma, blood glucose is decreased, less than 45 milligrams. Insulin is elevated. Because of this elevated insulin, blood glucose has dropped and polypeptides are elevated. These polypeptides are not elevated in hypoglycemia due to hypoglycemia produced by insulin or oral hypoglycemic drugs. That means a patient with diabetes mellitus is there who is regularly under insulin. If insulin dose has become little more, the patient may get hypoglycemic symptoms. So when he routinely or regularly, if he gets these hypoglycemic symptoms, then we should suspect whether it is because of insulin overdoses or because of insulinoma. So when you do C-peptide levels, they will be elevated only in case of insulinomas. If it is as a therapeutic injection, insulin is given, then the C-peptide levels are not increased because C-peptide levels are related to tumor cells. So because of the tumor cells, the peptide levels are increasing. Imaging studies, CT scan and endoscopic ultrasonography to localize the tumor and evaluate for features of malignancy. Treatment, localized or multiple adenomatosis, enucleation of those adenomas. If there is diffuse hyperplasia, we have to do subtotal pancreatectomy. In case of carcinoma, we have to do total pancreatectomy. Medical treatment indications, unresectable disease or unfit patients. Treatment is with diazoxide, which inhibits insulin release by beta cells, octreotide, and streptozotocin. So these will be helpful as medical line of management. So this is about the insulinoma, which manifests with hypoglycemia. Then the Zollinger-Ellison syndrome. It is a syndrome of fulminating ulcer diathesis in stomach, duodenum, and atypical sites, recurrent peptic ulceration despite adequate therapy, non-beta islet cell tumors of the pancreas, non-beta islet cell tumors. In the earlier stage, when Zollinger has discovered this particular syndrome, he has studied the pancreatic tumors, and then only alpha and beta cells were known. The other cells were not known. So when he studied it, they found that it is not from beta cells, it is not from alpha cells, but it is not from the exocrine glands of the pancreas. So that is why they first called it as non-alpha, non-beta islet cell tumor of the pancreas. So that is what the name they have given earlier. Later it was found that these are a special type of cells are there. They are called the G cells, which produce the gastrinomas, which cause the gastrinomas. G cells are present in some parts of in some other places also. What are they? G cells are present at other places also. What are they? A spiloracantrum. In all these endocrinal tumors, you must look for the other endocrinal abnormalities. That means most of the endocrine tumors can be a part of MEN syndromes. So you must always examine for MEN syndrome. Pathology of Zollinger-Ellison syndrome. This syndrome is primarily due to gastrinoma, which causes hypersecretion of gastrin. This leads to uninhibited and hypersecretion of hydrochloric acid from the parietal cells. This leads to fulminant and recurrent peptic ulceration in the usual sites, that means pylorocantrum, pylorus, juxtapyloric, duodenum, and lesical stomach. And unusual sites of peptic ulceration, that is second and third parts of the duodenum. Incidence: 20% of pancreatic endocrine tumors are because of Zollinger-Ellison syndrome. 0.1% of duodenal ulcers are due to these gastrinomas. They are common in males, age around 40 years. Most of them are found in the head of the pancreas. 70% of gastrinomas in MEN1 syndrome are located in duodenum. That is first and second parts of duodenum. 60% of them are malignant. This etiology also is not known. Site of occurrence of gastrinomas: most of the tumors from G cells are located in the gastrinoma triangle. This is also called as Pessaros triangle. Gastrinoma triangle is present at the junction of cystic and common bile ducts, then junction of second and third parts of the duodenum, then junction of body and neck of the pancreas. So if you draw the lines joining these three, that becomes the Pessaros triangle, and this Pessaros triangle has the G cells. So this means distal part of the pylorus, duodenum, first and second parts and part of the third part, then whole of the head and neck of the pancreas. Types of Zollinger-Ellison syndrome. Type 1 means antral G cell hyperplasia, which is rare. Type 2 means G cell hyperplasia or tumor from the pancreas, that is G cell tumor. Clinical manifestations: it presents like peptic ulcer or GORD, that means gastroesophageal reflux disease, in more than 75% of the cases. It should be suspected in any one of the following conditions: intractable or florid peptic ulceration. Normally we give proton pump inhibitors, which will cure the peptic ulceration in about 95% of the patients. In spite of high dose of PPIs, if the ulcer is not healing, then you should always suspect Zollinger-Ellison syndrome. Or if the ulcer is very deep, very acute, and very large in size, then also we must investigate the patient for Zollinger-Ellison syndrome. When there are multiple peptic ulcers, so some are in the first part, some are in the second part, some are in the pylorocantrum, then you must think of the Zollinger. Then recurrent peptic ulcers, peptic ulceration in unusual sites, second part of the duodenum. So it is very unusual for the peptic ulcer to develop, because in the second part of the duodenum there is papilla of water and accessory papilla of water. Through them, the pancreatic secretions will be poured into the duodenum. The pancreatic secretions are all completely alkaline. So any acid coming from the stomach will be neutralized by these alkaline secretions. So peptic ulceration is unusual in second part of the duodenum. But in Zollinger syndrome, there will be such high levels of acid, high quantities of acid are generated, means this alkaline juice coming from the pancreas is insufficient to neutralize that acid. So the acid causes invasion and causes ulceration of the duodenum second part also. So if peptic ulceration in unusual sites, then you must think of the Zollinger syndrome. Then any condition of family history of endocrinopathy, then patients of peptic ulcer with coexisting hyperparathyroidism or unexplained diarrhea, you should suspect Zollinger-Ellison syndrome. Differential diagnosis: chronic peptic ulcer disease, gastroesophageal reflux disease, and other conditions of hypergastrinemia. So this is one of the frequently asked questions in the PG entrance examination. What are the causes of hypergastrinemia? You tell me. One is Zollinger syndrome. We have seen G cell hyperplasia, G cell tumors. What else? What else can cause hypergastrinemia? CA stomach, yes. More than CA stomach, there is one more condition. Of course, I will discuss that one in the chapter on stomach. The causes of hypergastrinemia is atrophic gastritis, pernicious anemia. So atrophic gastritis and pernicious anemia, there will be increased levels of gastrin. Why they are increased, I will tell you and I will explain you when I tell you about this disease of the stomach in the next class. So atrophic gastritis, gastric outlet obstruction, retained antrum after gastric resection. Investigations. So whenever you see a patient of peptic ulceration which is florid, recurrent, or unusual, you must do these investigations. Basal acid output more than 15 millicrons per hour is suggestive of hypergastrinemia. Elevated plasma gastrin levels more than 1000 picograms per ml. Normally is only 100. If it is more than 1000, you should suspect hypergastrinemia. Secretin test. Increase in gastrin levels by more than 200 picograms per ml after injection of secretin occur in gastrinoma and differentiates it from atrophic gastritis, in which condition also hypergastrinemia is present. So if you inject secretin, the gastrin levels are increased by more than 200 in case of gastrinomas. But in case of atrophic gastritis, where there is hypergastrinemia, the secretin injection won't lead to hypergastrinemia. Gastroscopy to evaluate for the presence of ulcers in the duodenum or stoma of gastrostomy. Ultrasound or CT scan to locate the lesions in the pancreas. UAS to localize the lesions in the duodenum and pancreas for biopsy. Somatostatin receptor scintigraphy scan. Because this is not usually being done. Management, medical treatment, proton pump inhibitors, octreotide. In metastatic gastrinomas, you can give streptozotocin, 5-fluorouracil, doxorubicin. Surgical treatment. If you find a tumor that can be enucleated, In case of MEN syndrome, you have to do duodenotomy to evaluate for tumors in the duodenum. For type 1 Zollinger syndrome, that is due to hypergastremia of pyloric antral problem or G-cell hyperplasia of the pancreatic antrum, you have to do partial gastrectomy. For type 2, surgical treatment is advocated, that is enucleation of the tumor if discovered, or total gastrectomy if medical treatment fails. So this is about Zollinger syndrome. So this completes the topic of the tumors of the pancreas. Now we will go to the topic of injuries to the pancreas. Classification: external injuries and internal injuries. External injuries are mostly due to blunt abdominal trauma. Internal or intraoperative injuries. Internal injuries are mostly due to operative injuries. Operation during splenectomy can injure tail of the pancreas. When you do gastrectomy, then when the ulcer is adherent to the pancreas, then you can injure the pancreas. Enucleation of islet tumors of the pancreas, then you will injure the pancreas. During ERCP, when you are doing sphincterotomy, you may cut into the pancreatic head also and may injure the pancreas. External injury clinical presentation: severe epigastric pain due to leakage of pancreatic fluid into the surrounding tissues. So whenever pancreas is injured, the enzymes will seep directly into the surrounding tissues. This leads to paralytic ileus and as well as mild guarding due to peritonitis. Investigations: any trauma to the abdomen, you do certain investigations. They are same as those for the acute abdomen. So please tell me, what are the investigations you do for a case of acute abdominal pain? For any case of acute abdominal pain, what are the investigations you do? There are 5 investigations. You tell me those 5 investigations. There are 5 investigations. You please tell me in the order. First, what you do, first, second, third, fourth, fifth. The first investigation is urine for microscopic examination. If RBC are present, that indicates that there is a renal problem. If it is a trauma case, you will suspect there is injury to the kidney. That is number 1. Number 2, plain X-ray of the abdomen in erect posture. That is to rule out any hollow viscous perforation or injury. Number 3, ultrasound scan. That is to see for the stones in the kidneys, ureters, gallbladder, bile duct, and for the scanning of the appendix. Then, if ultrasound scan is doubtful, patient is obese and you are not able to get the information properly, you have to go for CT scan. Then you must do serum amylase estimation. So these are the investigations which you must do in every case of acute pain abdomen. They are urine for microscopy, plain X-ray abdomen, ultrasound scan, CT scan in relevant cases, and serum amylase estimation. So in trauma also you do the same thing. Plain X-ray abdomen, CT scan, serum amylase. These 3 will be done, of course, because I am talking about pancreatic trauma, these are mentioned, but if it is abdominal trauma, we don't know which organ is injured, then you should go for this urine examination for RBC and also ultrasound scan. Management, conservative approach is preferred. That is nothing by mouth and intravenous fluid administration. Monitor for signs of peritonitis and pancreatic leak. Surgery indications whenever there is disruption of the main pancreatic duct. So when you do CT scan, you can find out the disruption of the pancreatic duct. Procedure, you can go for distal resection of the pancreas. If there is injury to the head, drainage of the area, and if leak persists, we have to go for pancreatic duodenectomy. Late complications, there can be stricture of the duct. Then you have to go for distal pancreatic dissection. Pseudocyst, already we discussed in detail in the previous class. If it is non-communicating, you can do aspiration. If it's communicating, do cystogastrostomy or cystogenostomy. Yes, you have to send the urine for microscopic examination, because if there is small amounts of bleeding into the renal tract, the urine may not be stained red. It will be seen as cloudy. If you add just only 2 or 3 drops of blood to 1 liter of urine, then you won't see the red color. You will see only a cloudiness. But if you check the urine for RBC examination, then definitely you can say whether RBC are present or not. If RBC are present in plenty, that always indicate that there is some renal pathology. Pancreatic fistula definition: communication of the pancreatic duct to another viscus or to the exterior. Types: they may be external or internal. External means they communicate with the skin. Internal means they communicate with other viscera, peritoneal cavity or pleural cavity. The causes of external fistula: blunt abdominal trauma, postoperative, this is very common. Postoperative means following surgery on the pancreas, spleen, sphincter of Oddi, second part of the duodenum, or stomach. So if any one of these organs are operated, then because you are in the vicinity of the pancreas may be injured. So the pancreas is injured means then that can result in a fistula formation. So for this fear of fistula, many of the surgeons, they don't operate upon the pancreas. Because whenever fistula is there, the fistulas will be causing lot of headache to the surgeon as well as trouble to the patient. The other cause of external fistula being post-inflammatory. We have seen acute pancreatitis and chronic pancreatitis. So it forms an abscess. The abscess bursts outside and results in a fistula. So what are the problems with these fistula of the pancreas? Why surgeons they bother about this fistula? And patients have great trouble with this fistula because there is large amount of fluid and electrolyte imbalance. The normal amount of pancreatic juice secreted is about 500 ml per day. If all this goes away, the patient is going to lose a lot of electrolytes in form of sodium, potassium, and bicarbonate, because pancreas is rich in bicarbonate. In pancreatic fistula, due to hyperstimulation, excess of pancreatic fluid of about 2 liters per day is secreted. So normally it's only 500 ml. So when there is a fistula formation due to some inflammation or irritation, the pancreas will secrete more of fluid. So that will be around 2 liters per day. So this will result in loss of bicarbonate, fluid, electrolytes, and proteins also. Proteins, why? Because pancreatic enzymes are all proteins. So these enzymes are also lost in the secretions outside. Then these pancreatic enzymes, what they do is they cause excoriation and digestion of the skin. So they cause autodigestion and excoriation of the skin and pancreatitis, leading to bleeding and necrosis of the tissues. So this is an example of a patient. He developed acute pancreatitis about 6 weeks ago. Later, this fellow developed an abscess at the tail of the pancreas. He was treated. The pancreatic abscess gradually came into the left iliac fossa and it pointed out here. Afterwards, it bursts open outside onto the skin. So now from here, the secretions are leaking out. And because of the secretions, you can see all the surrounding skin has become excoriated, become inflamed, and gradually it will eat away all the epidermis and dermis because these are all the enzymes. So the pancreatic enzymes, they digest anything in the body. The management, mostly conservative, about 90% heal spontaneously. Aspiration of the contents by some suction and to replace the fluids and electrolytes by total parenteral nutrition. For example, if there is injury to the tail of the pancreas, usually during splenectomy operation, if you are not careful enough to protect the tail of the pancreas tail also will be included in the clamps. So when pancreas tail is also cut, then there will be leakage of enzymes from the pancreatic tail, and that causes pancreatic fistula. So what you do is you pass a large tube through this fistulous tract up to the pancreas. Then pass a finer tube with multiple openings and apply suction to this. What happens? All the fluid collecting here will be aspirated by this tube. You can ask me why to put two tubes here. You can put one tube. If you keep only one tube and aspirate, all the surrounding tissues will be sucked into the openings of the suction tube. One suction tube gets blocked immediately. So to obviate this problem, you pass a large tube with side holes. All the fluid will accumulate in this large tube. Then put a small tube in the large tube and aspirate the contents. This is how you aspirate. This is called the sump suction. Then give pancreatic suppressing agents like somatostatin or octreotide. You have to protect the skin by local application of zinc oxide paste and other emollients. If there is a stricture, the fistula will be continuously present. That's why you do ERCP followed by stenting of the duct if stricture is present. If the fistula doesn't heal, repair of the duct. If major duct injury is discovered on ERCP, or anastomosis in the fistula's opening to ruin by loop of jejunum. So that's about the pancreatic fistula. Before we close this topic, just we will discuss about how we approach to the pancreas surgically, because pancreas is deeply situated in the abdomen. To the head of the pancreas, we want to go to the head of the pancreas. You have to go by a procedure called cauterization. This is again an important short notes question. So where is pancreas here? You can't see the pancreas here because it's covered by duodenum on the convex border, anteriorly by the transverse colon, and pylorus of the stomach. So you can't see the pancreas. So how to go to the pancreas? First, you incise the phrenicocholic ligament. So there is a ligament coming from the peritoneal thickening is present between the diaphragm and hepatic flexure of the colon. So you cut this and make this incision into the paracholic gutter. The gut also is a mesentery. So you just cut the peritoneum here. Then this transverse colon, right 1/3, along with the hepatic flexure, can be displaced downwards. So it can be pushed down. So once you push it down, then you can see the whole duodenum, C loop of duodenum. Once the transverse colon is down somewhere, then you can see the whole duodenal C loop. What you do is then you make a convex incision in the peritoneum along the convex border of the duodenum. So inside the peritoneum here. So once they inside the peritoneum, then you can pass your fingers behind the duodenum. It is only loose areolar tissue will be there. So in this loose areolar plane, you can separate the duodenum from the retroperitoneum. And you can dissect up to the neck of the pancreas behind. So this is the Cockers incision. And afterwards, with your finger dissection, you can separate the duodenum and pancreas from the retroperitoneal areas. You can see here the portal vein. So you can separate it from the portal vein also by gradual gentle dissection. So this is called the cauterization. To the body and tail. Now you can see you are not able to see the pancreas at all here. You are seeing the liver, the stomach, the lesser momentum, greater momentum. So what you do is, if you lift the transverse colon, if you lift the greater momentum and transverse colon up, then you can see the posterior layer of transverse mesocolon. And also you are not able to see the pancreas. So pancreas is here. Anteriorly, the stomach, the lesser momentum, the greater momentum, etc. are present. So how to approach to that one? You cut the greater momentum from the greater curvature of the stomach. Once you cut the greater momentum from the greater curvature of the stomach can be retracted upwards and transverse colon can be retracted downwards. So you are entering into the lesser sac. Then you can go to the pancreas anterior surface. This is the greater curvature. Here is the momentum. So you detach the momentum from the greater curvature and lift the stomach above and push this transverse colon downwards. Then you can see the pancreas. If you incise the lower part of the pancreas, you can pass your fingers under the pancreas and you can feel the pancreas between your hands. If any stones are there or ductal thickening is there, you can examine. So this is the topic on the pancreas. Any doubts? If you have no doubts, we will go to the few topics that are left behind in the gallbladder and bile duct. We'll finish off those things. Subtotal pancreatectomy. That means you remove the body and tail and leave behind that part of the pancreas which is in the C loop of the duodenum. Any more doubts, please? Okay. If you have no more doubts, I will go to the yes. In distal pancreatectomy, for example, here, if you cut the pancreas here and remove this part, this pancreatic body cut section is exposing the duct. So what you do is you usually suture it, but there may be chance of leakage. So if a surgeon encounters that leakage in one or two cases, from next time onwards, what he will do is he will not leave it like that. He will not suture it like that. He will take the Roux-en-Y loop of jejunum and anastomosis to the tail of the or distal end of the pancreas cut section, so that if any leak is there, that will be there going into the jejunum directly. The dreaded complication of pancreatic surgery is leak. When pancreatic leak occurs, that causes a lot of misery to the patient as well as to the surgeon also. Okay, then if there are no more doubts, I will go to the topic of the bile ducts. So in the previous class, in the bile ducts, we have discussed about the colorectal cyst, Carolus disease, then stricture of the bile duct, then operative trauma to the biliary tract. So those topics we have discussed. Now let's discuss about the other topics. Biliary fistula. The types of biliary fistula being external biliary fistula and internal biliary fistula. External mucous fistula. It is burst mucocele or empyema of the gallbladder. If mucocele or empyema of the gallbladder is present, if they are open to the outside or burst to the outside, then they result in a mucous fistula. Then biliary fistula. Nearly all external biliary fistula follow operations upon the biliary tract. Causes injury to common bile duct during cholecystectomy operation. Already we have discussed in the previous class. Following cholecystoduodenostomy. Investigation to identify the site of the leak and to assess the anatomy of the bile duct. So the investigations being ERCP or MRCP. If they are not feasible or not available, you can go for PTC or radionuclide scanning. Fistulogram. If any leaking fistula is there, you pass a tube into the fistula and inject the radiopaque dye, and you see with what structure it is communicating, with the bile duct or gallbladder or hepatic duct, so you can make it out. So this is a PTC. Treatment of fistulae, mucous fistula, the gallbladder or its remnants has to be removed. Bile duct fistula, the continuity of the main bile duct must be restored. How do you restore bile duct continuity? If there is, for example, there is a fistulous communication with the common hepatic duct, how do you restore? For example, there is a leak from this place. What do you do? Yes, If there is a leak here, you have to restore the continuity by doing ERCP and stenting the bile duct. If it is not possible, then you have to do hepaticojejunostomy. As I said, you have to do hepatojejunostomy. If you try to suture the fistulous opening, it will cut through, it will break open. That's why you should not try to or attempt to do suturing here. You have to go for only hepaticojejunostomy. Yes, you can put the teat tube if it is in the common bile duct, but in the hepatic duct, it is difficult to place the teat tube in place there because the length of the proximal segment is not there. If you have a very short proximal segment, just only half centimeter or 1 centimeter, so the teat tube won't be held here properly. So if you pass it there, it will slip away. If it's common bile duct, yes, you can try teat tube. Okay, there was one doubt during splenectomy. There is a chance of distal pancreatic injury and pancreatic fistula. But we perform distal pancreatectomy. When we perform distal pancreatectomy, we know that we have cut the pancreas. That's why we carefully suture the duct. We carefully suture the parenchyma of the pancreas. And we leave a drain there. But when you are doing splenectomy, if pancreatitis is injured accidentally, if you have noticed it, then it's just like distal resection of the pancreas. You can suture it. If you have not noticed it, your intention is to do splenectomy. So you put the clamp in the splenic hilum, remove the spleen, like it. But in this process, you have included the pancreatic tile also, which you have not noticed. Then the pancreatic fistula results. If you notice it, then repair the pancreatic duct there. Then there is no problem of pancreatic fistula. So bile duct fistula, the continuity of the main bile duct must be restored. Internal biliary fistula, the biliary fistulas can be between the bile duct and neighboring organs. It is due to a stone ulcerating through the wall of the gallbladder or common bile duct into a hollow viscus. The communication can be between gallbladder and duodenum, colon, stomach. So gallbladder and duodenum, that is called the cholecystoduodenal fistula. Already we have discussed about this. Large gallstone sometimes ulcerates into the duodenum. When a large gallstone resides in the gallbladder, it causes chronic inflammation. Because of the chronic inflammation, there will be fibrosis around the gallbladder. So this fibrosis will cause adhesion between the gallbladder and the duodenum. Then this can gradually cause ulceration in the mucosa, and this ulceration can deepen because of this presence of this large foreign body. So this foreign body gradually ulcerates through this adhesion, and it goes into the duodenum, and there it can cause obstruction to the duodenum. If it is smaller in size, it can pass down and can obstruct the small bowel. This is the commonest internal biliary fistula. The stone may impact, leading to duodenal obstruction. If smaller, it may cause intestinal obstruction. If it causes intestinal obstruction, which part of the intestine will be obstructed commonly? The narrowest part of the small intestine. So my question is, what is the narrowest part of the small bowel? Can you specifically say some point? It is not duodenal junction. It is not ileocecal junction. Okay, it is the small bowel, that is ileum, 60 centimeters proximal to the ileocecal junction. That is the narrowest part of the small bowel. 60 inches, 60 centimeters proximal to the ileocecal junction. So that is the area where Meckel's diverticulum is usually present. So that is the narrowest portion. I hope you are seeing the slides as well as I am audible. Okay, that's fine. You can see here it is a case of a radio opaque density you are seeing here with the dilated bubble shadows here. So this is due to a gallstone blocking the small bubble. So whenever you suspect gallstone, you must always see for the air shadows in the right upper quadrant of the abdomen. Normally in the liver or in the bile ducts, there will not be any air. But if there is presence of air streak like this in the gallbladder or in the bile ducts, that means that there is communication of the gallbladder with the intestinal tract. That is why air has came into the gallbladder. So there is a point to suggest that it is a gallstone obstruction. Next topic is cholangitis. It is inflammation of the biliary passages. Types: primary or idiopathic and secondary. Secondary to stones or worms in the common bile duct. Primary sclerosing cholangitis. Name also itself tells that it is cholangitis and it is having sclerosis. Pathology: idiopathic chronic sclerosing inflammatory condition of the biliary tree affecting both intra and extrahepatic bile ducts. So it is a sclerosing inflammatory condition of the biliary tree affecting the both intra and extrahepatic biliary ducts. It is associated with ulcerative colitis in about 50 to 70% of the cases. Complications: bile duct carcinoma and biliary cirrhosis. Clinical features: age less than 50 years. There is progressive cholestatic jaundice with right hypochondriac pain, fever with chills and rigor because there is cholangitis. So the symptoms of primary cholangitis are same as the secondary cholangitis. There is Charcot is there. If you don't find the cause, you call it as primary. If you find the cause like worms or stone, then it is secondary. Investigation: alkaline phosphatase is elevated. Ultrasound scan shows dilated ducts or constricted ducts. ERCP shows stricturing and beading of the bile ducts. So when do ERCP, there are multiple places of strictures. The whole bile duct will be strictured. Treatment: surgical treatment is difficult as the disease has diffuse biliary tree involvement because the whole biliary tree is narrowed, so we can't do any treatment. Conservative treatment: antibiotics, vitamin K, cholestyramine, steroids, and azathioprine. If liver failure supervenes, you have to go for liver transplantation. Parasitic infestations of the biliary tract. They are due to Ascariasis, Clonorchis sinensis, hydatid disease. Ascaris lumbricoides may enter the biliary tract through the ampulla of Vater. and cause biliary ascariasis. Manifestations: suppurative cholangitis, stricture formation. You give anti-inflammatory drugs and antispasmodics to relax the sphincter of body. ERCP is done where you can identify the worm and you can remove the worm through the papilla of water by sending a basket. Surgery is choroidicotomy and removal of the worm. So, but ERCP is ideal. Just I will show you one small video clip of this ascaris removal. You can see to the papilla of water, a cannula is being sent and ERCP dye has been injected. Then a worm was found. So then a basket was passed into the papilla of water. So it was a failure. They could not remove the worm. Again, an attempt is made to pull out the worm. You're seeing all the bile is coming out with frothy nature. Now you can see the worm ultimately has come out. So this is the tail of the worm. You can see here. This is the worm tail is seen. So now a basket is placed to catch that tail. This is all the duodenal lumen. This is the papilla of water. This is the worm coming out. How nicely the tip of the tail of the worm is seen here. You can see now the basket opens to try to hold the tip. The worm sensed it and then it has dragged inside. Now again the basket is sent inside into the duct. So it is successfully caught there. You can see the movement of the worm. It is being retracted out of the papilla of water. So you can see that worm So this is the worm that has been taken out. Then the other worm is the Clonorchis sinensis. The disease is endemic in the Far East. Is not seen in our country. Pathology: the fluke up to 25 millimeters long and 5 millimeters wide, lives in the bile ducts and intrahepatic bile ducts. It produces strictures of the duct, leading to stasis. Stasis leads to stones and cholangitis. It causes biliary cirrhosis. It causes cholangiocarcinoma. Clinical features: it says usually before removing the worm, anti-helminthic drugs will be given. But the anti-helminthic drugs, they will not act much if the worm is in the biliary duct. If it is there in the intestinal tract, they will be killed or they will be paralyzed. But if they are there in the bile duct, unless the drug comes into the bile, so they won't be paralyzed because they are not exposed to the environment of the drug. The amount of drug that is secreted in the bile is very minimal. That's why usually they are of not much use, but routinely the anti-helminthic drugs are administered to the patient. Okay, the Clonorchis sinensis, the many cases are asymptomatic. There will be features of cholangitis, treatment choledochoduodenostomy, and access loop choledochojejunostomy or hepatojejunostomy to manage the recurrent postoperative strictures. This is called the access loop hepatojejunostomy. Of course, this is not necessary for you. Pathogenesis of cholestatic jaundice and hydatid disease of liver, already we discussed. A large hydatid cyst may obstruct the hepatic ducts. Sometimes a cyst in the liver may rupture into the biliary tree, producing obstructive jaundice or cholangitis. So there are two mechanisms. One is a large cyst may displace and distort the bile duct, producing obstructive jaundice. Sometimes a hydatid cyst in the liver may rupture into the bile ducts, liberating small daughter cysts into the bile duct, which packs the bile duct and causes obstruction. Treatment is ERCP and removal of the daughter cysts and stenting. Later, hydatid cystectomy by open or by laparoscopic method. If ERCP is not available, we can do choledochotomy. Choledochotomy and removal of the cysts in the biliary passages, followed by removal of the hydatid cyst of the liver with closure of the communications of the cyst with the biliary passages. So open the bile duct, remove all the daughter cysts, and then open the liver, take away the cyst. Already we have studied about the hydatid cystectomy procedure. So look into the cavity. Any communications with the biliary duct has to be ligated. So this is what you have to do if it is a case if ERCP is not available. If Shruti has a doubt, if there are more worms in the bile duct, that means Ascaris worms, if there are more, then how are you going to deal? On ERCP, first you do ERCP. On ERCP, you will observe how many worms are there. So you try to remove all those worms. Then you inject the dye again into the bile duct and check whether there are any remnant worms are there or not. So that is how you usually evaluate. Tumors of bile ducts classification: papillomatosis and carcinoma. Carcinoma of the bile duct. Etiology, bile duct stones, 25% of the cases, sclerosing cholangitis and ulcerative colitis, then choledochal cyst, clonorchis sinensis infection. Clinical features, cold steady jaundice and jaundice with tumor jaundice. That means there will be progressive, painless, persistent jaundice. Investigation, ultrasound scan, ERCP. During ERCP, you can do cytological brushings taken from the bile duct during endoscopy. If ERCP is not possible, you can go ahead with PTC. Treatment, endoscopic treatment and surgical treatment. Endoscopic treatment, brachytherapy via nasobiliary, balloon dilatation. What is brachytherapy? Do you have any idea? That means you do ERCP and you introduce radioactive tantalum wires into the tumor directly and leave them there. These radioactive wires, they are introduced into the tumor tissue. So they give radiation at the place of tumor and the tumor gradually necros. This is called brachytherapy. Brachytherapy is also called as the interstitial therapy. If stricture is there due to the carcinoma of the bile duct, you can do the balloon dilatation followed by stenting. So this is a cholangiocarcinoma blocking the bile ducts. So first you pass the guide wire. Over the guide wire, you pass a balloon and dilate the balloon. So by that, you can gain the passage here. Then after dilatation, you can pass a stent here. So stent is passed. So this is stenting, balloon dilatation followed by stenting. If the tumor is localized to one lobe of the liver, like this, you can do hemihepatectomy or excision of that particular lobe. The tumor is confined to the extrahepatic bile ducts. This is for intrahepatic bile ducts. If it is for the extrahepatic bile ducts, resection of the tumor and reconstruction of the biliary tree. That means, for example, if this common hepatic duct is involved with cholangiocarcinoma, so remove this common hepatic duct and right and left hepatic ducts. Then you take a Roux-en-Y loop of jejunum and implant the right hepatic duct and left hepatic duct into the loop of jejunum. If the tumor is there at the terminal end of the common bile duct, it is treated like periampullary carcinoma. That means you do Whipple's resection and do the anastomosis like this. Clastin tumor means a Y-junction tumor. That means right and left hepatic ducts and common hepatic duct. That junction is called Y-junction. So if the Y-junction tumor is having a cholangiocarcinoma, it is called the clastin tumor. The IPMN tumors, they are usually benign tumors. Sometimes they can be malignant. In malignant tumors, it is always preferable to do resection. The brachytherapy is done only as a palliative measure. So if it is operable, it is always better to go for the resection. And cystic tumors, they are easily amenable for surgical management. So it is always preferred to remove them rather than doing the brachytherapy. Technically, passing the stents into the IPMN is difficult. So brachytherapy can be done only by few expert gastroenterologists. Palliative operation, intubation. That means if the tumor is inoperable, patient is having cholestatic jaundice, then you can pass a tube across the tumor and leave it like that. If possible, you can do biliary enteric anastomosis. So you can take a loop of jejunum and anastomose to the intrahepatic bile ducts like this. If it is terminal end of the bile duct, you can anastomose it to the gallbladder as cholecystogeganostomy. The last topic of this gallbladder bile ducts is carcinoma of the gallbladder. The tumors of the gallbladder, benign adenomyomatous polyp, that is cholesterosis, already we discussed during our previous discussion. What is the other name for cholesterosis of the gallbladder? What do you call that? What do you call that gallbladder? Cholesterosis of gallbladder. Yes, very good. It is called strawberry gallbladder. Then other benign tumor is adenomatous polyp. It is less than 1 centimeter size and it can transform into malignancy. Then malignant tumors of the gallbladder, that is adenocarcinoma. The carcinoma gallbladder, this is rare in Western world. It's common in Chileans, American Indians, and some parts of the North India. Age more than 70 years. Females are commonly affected. Etiology not known. Gallstones are present in more than 90% of the cases, so gallstones may be a predisposing factor. And porcelain gallbladder predisposes to cancer. What is porcelain gallbladder? Yes, chronic cholecystitis with calcified gallbladder. Types of carcinoma: serous carcinoma, squamous carcinoma, spread by direct invasion through the mucosa into the serosa, from there into the liver, spread by lymphatics and by bloodstream. Clinical features: incidental finding at cholecystectomy operation or at the time of histology. That means when you are doing cholecystectomy for gallstones, so you may notice a mass in the gallbladder. Or you did cholecystectomy and sent it for histopath examination, then histology shows that there is a mass in the gallbladder. So there is incidental finding, which can usually this is the finding. The other types of presentation is as cholecystitis or as mass in the right hypochondric region. This occurs in the late cases. Treatment for polyps of the gallbladder: more than 1 centimeter cholecystectomy, less than 1 centimeter follow-up and monitored by ultrasound scan. For early gallbladder carcinoma, radical excision, that is gallbladder, adjacent liver segments, bile duct, and regional lymph nodal excision is done, followed by Roux-en-Y anastomosis. For advanced disease, palliative treatment with chemotherapy. Jaundice is relieved by PTBD or by ERCP. If the disease is diagnosed after cholecystectomy and the tumor is confined to the mucosa, it carries a good prognosis and nothing more is required than follow-up of the case. For transmural spread disease, you have to plan for radical en bloc excision of the gallbladder fossa and surrounding liver, along with regional lymphadenectomy has to be done. Prognosis: gallbladder cancer carries bad prognosis. Mean survival is only 6 months. 5-year survival rate is 5%. So with this, we complete the topic of gallbladder and bile ducts also. So we have completed the disease of the pancreas, gallbladder, bile ducts, and liver. That means biliary and pancreatic diseases. Then from next class onwards, we will study about the luminal alimentary tract. That means the stomach, small bowel, large bowel, rectum, and esophagus. So, yes, if it is confined to the mucosa, the survival will be very good. It will be just like a normal person. But this is only for the gallbladder cancer, which has usually they manifest either during cholecystectomy operation or as a mass. If they are presented as a mass with transmural spread, then this is the survival rate. But if it is there confined to the mucosa, the survival will be good. It is not like this. It will be as good as having a normal gallbladder. So in gallbladder fistula, even if you do suturing, it will break open because the cause is not corrected. The cause is mucocele or empyema. The mucocele or empyema occurs because of stone in the cystic duct. So if you remove the stone and suture the gallbladder opening, it heals. But again, it recurs because once a stone has formed means there is evidence of chronic cholecystitis. So once cholecystitis means the gallbladder is chronically inflamed. So it will cause repeated problems to the patient. So the treatment for symptomatic chronic cholecystitis is cholecystectomy. So tomorrow is a holiday. We don't have the class. From day after tomorrow also, from day after tomorrow, we'll go to the topic of the stomach, disease of the stomach. So I'll put the details of the classes on the website, either today night or tomorrow morning. So you can go through that and you can act accordingly. So we'll go to the topic of stomach diseases. Any doubts? Definitely at the end of the GAT, we'll definitely will have some case discussions. So I'll present some cases and discuss with you. So in that, automatically the differential diagnosis, the management, everything pertaining to that particular case comes. I will show you some cases and then I will discuss with you. If you have no more doubts, let's close this session and then meet again day after tomorrow at 4 p.m. Wish you all good night. Thank you and bye.